Right, good afternoon. My name is Stefan Dercon. I'm the director for the Center for the Study of African Economies. We have this afternoon a panel around a very important topic for Sub-Saharan Africa. Of course, we are all still doing this online and Zoom because of the pandemic, but it's still important to reflect on that this is not over, and we're still having countries working through the pandemic, and we're trying to still look for ways to overcome it. It's very hard to give a really final assessment of how the pandemic has really affected Sub-Saharan Africa, and hopefully as part of this panel we'll get maybe also some additional insights on this. Globally, I'm still struck, if I think back, in February 2020, I got an email from someone working in the Oxford Vaccine Group and saying, look, this may well be 10 million people that may die from the pandemic here. If we think of it where we are at the moment, we have officially, of course, numbers around 6 million, but those studies that are actually making an assessment of the overall impact of the pandemic through excess mortality, as for example, 2 weeks ago, a study by Wang et al. In the Lancet would put a number now at something like 18 million of excess mortality across the world. When we look at the impact on Sub-Saharan Africa, there was a bit of a puzzle for a while, but even now the figures start looking like, actually it's not that much different from the global excess mortality estimates. At least that paper would suggest something like 102 per 100,000 people died more than the normal mortality figures would have predicted. Globally, this may be around 120 per 100,000. But of course, even these modeling exercises, and these are not necessarily the best data and whatever, because it's really hard to assess it. But Southern Africa definitely would have multiple of this. Now, even if it's then maybe global for Africa, it doesn't look as bad as we may have thought relative to global figures. We should not forget Africa has the youngest population, and it shouldn't have been some of these kind of numbers. It has relatively low population density and so on. So anyway, so it still feels like, this is something that is causing a lot of harm to people, to societies, to economies. And early on, it became clear that beyond therapeutics, vaccines would have to be part of that exit option for the world. Lots of big statements have been made since then by richer countries that they were going to vaccinate the world. All of these efforts feel much slower than we may have expected. And we want to have today's panel to actually get a further discussion around it, getting some further ideas and maybe the hopes and fears of how the pandemic in Sub-Saharan Africa can evolve and where we can get to with vaccination. We have three eminent speakers, incredibly qualified to talk to this topic. Let me actually introduce them in the reverse order in which they will first give some opening remarks. We have first David Kinder, who is from the Global Alliance for Vaccine Immunization, where he's the Director of Development Finance, responsible for GAVI's relationship with multilateral development banks and international financial institutions. He's a very experienced international public servant, having also worked in the UK civil service for many years. Secondly, we have Dr. Mercy Mwangangi. She's the Chief Administrative Secretary in the Ministry of Health in Kenya. That means, if I understand it well, she essentially runs the department. There is a cabinet secretary that would be in the cabinet of the president, but she is essentially in charge of the department. She is a hugely experienced a health professional, and in recent years very actively involved in, for example, in the Big Four agenda of President Kenyatta around universal health coverage pilot program, and many other things, and more details are of course also on the website. And last but definitely not least is Sir Andrew Pollard. Professor Andrew Pollard is the director of the Oxford Vaccine Group. For many of us, he's also been the important face of the whole development of the Oxford AstraZeneca COVID-19 vaccine, where he was the chief investigator for the clinical trials which then in the end led to the authorization of the vaccines for use in more than 175 countries across the world. 2.5 billion doses were distributed by the end of 2021, and definitely his and his team's efforts have played a huge role in at least containing and hopefully ending in due course the pandemic. So this is our panel, and I would like to ask Sir Andrew to actually maybe give his point of view, where we are with the hopes and fears he has around both the pandemic and vaccinating the world, and anything else he feels like he wants to communicate to us. Thank you.
Thanks very much, and thanks for inviting me to join the panel today. I think a good place to start perhaps is just in the big picture, sort of following on from some of your introductory comments with that very frightening figure of perhaps 18 million excess deaths. And we think in those that are documented as COVID deaths, and that there's at least 5 or 6 million, but I think the reality is going to be at least 2 or 3 times that. So I'm sure 18 million won't be far off the mark. But the other way of looking at it is that we've actually been pretty lucky. That's a pretty low number of deaths in a pandemic. It's less than 1% mortality from the cases in the first couple of years, and far less than experienced, for example, in the Middle Ages with the Black Death, with about 50% mortality. Half of the population of Europe wiped out by that pandemic. And then even if we look at other coronaviruses, which over the last 20 years have been a threat to human populations, SARS in 2002 killed about 11% of those infected. MERS coronavirus about 10 years ago killed a third of those infected. So actually we've been rather lucky with the mortality that we've seen. It doesn't feel like that at this minute. And you look more broadly at the social disruption that there's been and the psychological impact that there has been, particularly for young people. It is enormous. And of course, much of those same problems that here in a high-income country that we're familiar with, the impacts on education, on the health system, are also true across the continent of Africa. Certainly colleagues that I speak to regularly are so much more aware of if you're at the poverty line and there's some restrictions on your ability to work that's caused by social distancing and lockdowns, it tips people over the edge. So I think when we think of this, and there's been a lot written about the impact in high-income settings, those are amplified in many ways to the populations in low-income settings, to the extent even where lockdowns are just not practical because the alternative is mortality from this disease or starvation. And that really is a different way of thinking about the pandemic from the way it's often been framed. The other aspect is that during 2020, we really had no tools at all at our disposal that could mitigate the effects of the pandemic, apart from physical distancing measures. And if you live in a setting where it's possible to physically distance and to be in lockdowns where there are small bubbles of individuals, you can very much reduce the impact of the virus. But in many situations in low and middle income countries, people live in much more multi-generational households. There isn't the ability to separate individuals in the same way as happens in high income settings. And so the infections spread much more rapidly when they arrived in some of those populations. And I think this is a really important component to think about when we're now thinking about the future and what the different populations around the world look like today, because we're not the same as we were 2 years ago at the start of the pandemic. So just to give some perspectives on exactly that point, here in the UK and across much of Europe, we have a highly vaccinated population that is also has met the virus. A huge proportion of people have been infected as well as vaccinated. And we've had our early problems before vaccination of very large mortality. But now we're largely in a very low mortality setting. We're still seeing lots of spread of the virus. And that is actually building immunity in the population. Hopefully in the future, the transmission will be much more spread out and we'll reach some sort of a steady state. Now, we don't, surprisingly, scientifically know what that looks like. It could be that we end up like flu with seasonal outbreaks, or it could be that we end up with sort of a background level of transmission. And we just don't know where that's set. Is it set where we are at the moment, or is it set somewhere lower? So that's sort of the pattern that we have here. And I think it's really interesting today to look at Hong Kong, a setting where it was possible to pursue a zero COVID policy, which of course was the best thing to do when there was a lot of spread of the virus and no mitigation in 2020. But that only works is if you use that time to then generate immunity through vaccination in the population. Of course, what's happened in Hong Kong, they've had zero COVID, the envy of the world, like New Zealand. But unlike New Zealand, there hasn't been widespread rollout of vaccination. So as the virus has arrived now, and of course Omicron and now BA2 spread so effectively, even with social distancing, and that population is now suffering a pandemic that looks like it did 2 years ago for us. And in the elderly care homes, only about 15% of the elderly have been vaccinated. The virus has arrived and intensive care units are full. It looks exactly like those awful pictures that we saw projected around the world of ICUs in high-income settings. Now, that is that setting, but we look now at Africa, and it's completely different, because although vaccine uptake is far behind high-income settings, the virus has spread very readily around most populations, not completely. And there's actually quite a lot of background immunity now as a result of infection. And that is sort of good and bad. It's bad in the sense that many of those individuals who were susceptible to severe disease or death have already met the virus and have succumbed, because we didn't intervene with vaccines early enough and to have that impact. One of the critical lessons that we didn't need to learn in this pandemic, we already knew it. In outbreaks, vaccines only work if you use them before you're dead. And the problem with much of the world has been that rollout has happened too late. And so you mentioned these promises of Western governments to provide vaccines for Africa in 2022. That's very late in a pandemic. You need to be providing vaccines before people have died. And so I think really we're talking about a setting now, and all the discussions about what happens next around vaccination in Africa are in the context of an enormous impact that the virus has already had on the continent, and much less that you can do with vaccination now than you could have done a year ago. And I feel quite proud, at least for the Oxford vaccine, that in the first half of 2021, it was about 90% of the supplies through COVAX, and it did get rolled out to low and middle income countries at that time, before there was the later waves of the virus had appeared. But really, most of the increased supply for those individuals has come very late. You also raised the question of the differences in mortality that there might be in different settings. And I think you're absolutely right to raise the issue of the age pyramid being very different in Africa. So we do know that everywhere in the world, young people are much more resistant to severe disease, and that's just as true in Africans as it is in Europeans. But the elderly, wherever they are just as susceptible. And what we haven't done in the way that vaccines were prioritized globally is prioritize the elderly and those with health conditions in Africa in the same way as we did in high-income settings. And it's actually pretty shameful that we were vaccinating 20-year-olds here in the UK and boosting at a time when in low-income settings, including across the continent of Africa, there were people dying who were over 65. And I think it's very difficult to think about how, or from an international policy perspective, you address that, because that isn't something which national politicians are focused on. They're perhaps rightly elected by their electorate in order to protect their own country. But it does mean that we need to think about, again, now about how we make sure that the international policy is enshrined in a way that it does make good sense in global public health, that you prioritize those at risk of dying first before you start vaccinating those who are at extremely low or zero risk. So I think that's an important component. So what about today in Africa? The big problem at this moment is there is a proportion of the population who have neither been vaccinated or infected. And we just don't know who those people are. So it still makes absolute sense today to be vaccinating those individuals who may be at risk in the months ahead, and that's the elderly, those with health conditions. And that is really the focus of what has to happen. Some countries are doing better than others in doing that, and there are both have been up until now major supply issues, but there's also some political issues and definitely issues around the infrastructure required to deliver vaccines and increasing problems with hesitancy. And I think, and I'm sure David will speak to this, but we are now at a point where supply is not the obstacle to roll out of vaccines from a global perspective. The real challenge today to get to that subset of the population who are still at risk are the distribution mechanisms, which involves both GAVI and COVAX ability to provide vaccines at a way that's copable with by countries, but then also the infrastructure internally. And today, in many parts of the world, major issues around vaccine hesitancy. If we look at Eastern European countries, many of those have extremely low vaccination rates. Bulgaria, about 25 or 30%, similar in Ukraine, of adults have been vaccinated, sorry, the whole population has been vaccinated. And that means that there will be individuals in those populations as well who are at risk, particularly at this time when there's refugees moving crowded together across European countries. So there's some real challenges ahead caused by vaccine hesitancy. So if we project into the future, what does the world look like? Well, I certainly hope that these issues over distribution will be improved for Africa. But I'm actually pretty optimistic about where we are. As long as we can increase immunity in those who are not yet vaccinated, then we are in a very good place. And you just look at the contrast between the UK today with huge numbers of cases in our community, but really very manageable level of activity in the health system. Not zero. I'm not a denier of the problem of there are still cases, but it is a much lower issue than it has been at any time over the last 2 years, and something manageable by the health system. But that raises the second problem for many countries in Africa, which is that the health systems are relatively weak. So if you do have a high burden of disease occurring, you get to the edge of capacity in the health system much sooner than you do in countries that have many hospitals and a lot of beds per head of population. So those are additional challenges. But as I say, I'm optimistic that as we go through this year, immunity will continue to improve, and we'll be able to much better globally cope with this virus being with us. But it ain't going to go away. And so we need to continue to think about what are the requirements for Africa beyond these initial doses of vaccines. Are the people who are going to need boosters in the future to keep them out of hospital? Are there people in the population who are very severely immunocompromised who will need treatments? And there's very little progress still on getting novel treatments into African populations. But hopefully those are going to be issues which are at a much lower level than we've experienced in the last 2 years. And we should be an improving situation. And perhaps I'll end my comments there.
Right. Well, thank you so much for these introductory comments. To the audience, if you have any questions you want to ask, please put them in the Q&A function. I will then either put you on the microphone or just read them out. You can show that. We'll have plenty of time for questions after the 3 contributions, and I hope you will put these to this panel. Dr. Mercy Mwangangi, what does it look like, and in view of the comments of what Professor Pollard is giving us, what does it look like in Kenya from where you're sitting, please?
Thank you, Stefan, and let me also extend my appreciation to Professor. I enjoyed listening to his comments and sort of trying to reflect what the situation looks like in Kenya. Well, the story of the COVID-19 pandemic, I must say, has taught us as individuals, as Kenyans, but also as government, a lot of what we need to do when it comes to managing pandemics, a lot of what we need to do, investments that are needed when it comes to health security. As we speak today, right now in Kenya, the numbers are very low, much like is the case in the UK and a few other countries across the world. I was looking at the data today, and our positivity rate, which I do appreciate is not the best metrics, but it's one of the ones that we use, stands at 0.4%. And when I look at our mortality in the past 3 days, we've had 0 mortalities in terms of at least those that are reported in the system. And when we look at our ICU admissions, oxygen use, I think we only have about 2 people on oxygen right now across the country in all our COVID units. So certainly in terms of, the surge of the disease and the high waves that we had, during the peak of the pandemic, we are hoping that that is behind us. Of course, the jury is still out. We're still waiting to understand what steady state looks like. And I don't think anyone anywhere knows what that looks like. But of course, I'm sure globally, there's a lot of work underway to determine where that level or threshold will be. In terms of perhaps just generally in managing a pandemic, and particularly trying to look at our subject today and trying to use the lens of health financing and economics in terms of how Kenya managed this pandemic, I think one of the most important lessons that we learned was that there's need to always have very agile governance structures. It's one thing to be able to identify gaps in different areas of financing, in different interventions, gaps in then at the time, supply of vaccines, gaps when it came to human resource, gaps when it came to the needed infrastructure. But I think perhaps one fundamental lesson that we've taken as a country is that you do have to have a very agile governance structure when it comes to managing health pandemics. And of course, Kenya does, of course, have a Ministry of Health. I work there as a deputy minister there, and we have a whole structure, a whole surveillance team. But what we learned is that, particularly when it comes to issues of procuring during emergencies, when it comes to that needed agility and dynamism in trying to deal with a pandemic, there's need to have almost a fit for purpose institution that is able to deliver that. And so in Kenya, most recently, actually 3 weeks ago, the president was able to enact via legal notice what is known as Kenya CDC. So we now will have an organization that is tasked with essentially providing disease surveillance services in the country. It will have the, again, agility and how do I say, ease of work to be able to act very quickly during a pandemic. It will have certain mandates that we realized are necessary during a pandemic. For example, I think most countries struggled with the masking mandate and even the lockdown mandate and the social distancing mandates. But now we have an organization that is armed with the legal teeth that it requires to be able to do this. And then, of course, because of the lessons that we learned during COVID-19, particularly the challenges we experienced when it came to financing, ensuring that, different ministries of finance, exchequer are able to avail the resources that are required in the manner that they're required, with the speed that they're required. I remember instances where there was need for direct procurement of different interventions, masks, cannulas, high oxygen flow cannulas. And some of these were only available in most of the time actually in a country that's beyond Kenya. And of course, if you look at our procurement laws, there were challenges in being able to get those. And so really what we are doing now, particularly when it comes to governance and structure, is getting this institution ready. It's already been enacted. We're in the process of filling in the staff establishment. And most importantly, it has a budget, and a budget that understands how finances should flow during a pandemic. And that's very important. When we look at then, of course, beyond how we governed our response, particularly now into the key interventions, yes, we did have challenges when it came to enforcing lockdowns. There were challenges when it came to enforcing social distancing, particularly when you look at Kenya and more so Nairobi, which is an urban town in Kenya, where you have high density populated areas, much of what people call slums, most like concrete jungles. It was difficult for you to be able to tell a family of 6 who live in a 1-bedroom house to isolate. And remember, they have, probably the head of the household who needs to go and fend for food and be able to bring something home for food. So of course, there were difficulties there. And so I must say, as government, we took a very moderate approach in terms of how we rolled out our COVID response. I must say our lockdown was moderated. It was also coupled with different stimulus packages, and different subsidies were put in place. And it was clear that there are certain parts of the country that you simply cannot lock down. Kenya is a transport corridor for trade within the East African community. And so it was important to ensure that our borders were open. Some of the countries who rely on the corridor through Kenya are landlocked countries. Kenya has the benefit of having a port. And so it was necessary to keep those borders open, but still to ensure that some form of response, some form of surveillance was going on in those areas. And I think, despite the challenges that were experienced, and particularly most of them being that this was a new sort of disease and a new sort of state that we were dealing with as Kenya and as the world, I think we were able to manage that. Goods were able to move within the different neighboring countries. And in that regard, then food supply was sustained. It is a bit challenging, I must say, at some point for the country, because we were also experiencing a drought at the same time. And so you can imagine dealing with a drought and a pandemic all in 1 year, and the strains that that put on the parks, on the kitty. However, I must say, looking back, I think our moderated response, which I could take probably days to describe, because there was a lot of people always having their pulse on what was going on, and for us to be able to either tighten or loosen a restriction, sort of aided us in being able to navigate through the pandemic. Of course, one key thing, particularly when it came to raising finances for the pandemic, I think Kenya was a good showcase of what it means to have public-private collaborations towards this. We had a lot of support from the private sector, and this includes private sector providers, so health sector providers, hospitals and HMOs and that kind of provider. But I'm also talking about the private sector at large in terms of corporations and corporates, different industries who are in, hygiene spaces were all able to really contribute, particularly in the beginning of the pandemic. And what is interesting, and what is, this is one of the things that Kenya will carry forward, from this experience, is for the first time in the country, we were actually able to fashion what was known as a COVID-19 fund that included the blending of both public and private financing with administration from Exchequer and from the private sector. And that was sort of a novel idea here in Kenya, particularly when it comes to mounting a public response. And so that fund still exists. It has a board and it's running, and has gone on now to move its primary intention being, a lot of support towards the measures of social distancing and lockdown, towards trying to create advocacy for vaccines and vaccine uptake. So really, I think that was, one of, should I say, the nuances from our experience here in terms of how we can, make use of blended financing when it comes to public health responses. In terms of the provision of Exchequer resources, I must say from the very outset, there was great political commitment from His Excellency the President, Uhuru Kenyatta. He actually was the chair of the summit coordinating body for the pandemic. And so he was regularly in attendance for all meetings, including those that required Exchequer financing and deliberation on budgets. And so right from the beginning, I must say, and having been in the Ministry of Health for at least 13 years, it was good to have the spotlight on the health sector for once. We were able to see at least, a modest increase in our budgets. And of course, beyond even the budgets, was a lot of ancillary support to the Ministry of Health. Going forward, I think one of the things that we'd carry on, particularly when it comes to health security, it will be difficult to disinvest in that space within, into perhaps another sector within government. And so that's a good thing for health. However, internally, if you do a disaggregation, you will notice that there were areas that suffered within the health system. So one, when it comes to continuity of essential services, we did have challenges, particularly during lockdown, social distancing times, where we had fewer mothers coming in for delivery at the health facility. We had fewer children being presented for their routine childhood immunization. We had people who suffer from chronic diseases, hypertension, diabetes, missing their clinics. We had, of course, delayed surgery lists. And so, of course, all these have effects in terms of course, health indicator impacts, but also beyond in terms of the country. And we have done some work. We've done a lot of analytical work. We are actually in the third phase of trying to compute what the impact of that was in the country. And, using our routine data systems, we are trying to put that together to see what injuries we may have received. That being said, I must say that we are seeing a rebound, particularly just in the routine indicators. Our skill delivery rate was about 70%. During the first days of the pandemic, first months of the pandemic, it did drop down to maybe 50. We are back now at 72. And this is the case of all the indicators that we measure, that sort of, particularly the basic indicators that tell us of the resilience of the health system. I must say, again, there was a great fear, and particularly when we saw the pictures of what was happening across the world in the initial stages of the pandemic. And perhaps that fear was a good incentive, because what we did is potentially moved from having just 2 isolation beds in the country to 7,000 beds within a span of 3 months. And so there's a lot of investment when it came to what you call the specialized tertiary care services in the country. We moved from having about 3 oxygen plants in the country to more than 47 oxygen plants in the country. We moved from having, it was 4 labs that were able to do PCR testing to now 94 labs in the country that are able to do PCR testing. And so there is, the story of COVID-19 for Africa and for Kenya, and I suspect for much of Africa, is that of a double-edged sword. While our systems were, I'd say, inherently weak due to perhaps underinvestment, they then did, of course, enjoy a very intense surge of investments. And so that capacity that was increased, even in human resources, we were able to hire about 2,000 healthcare workers within a span of, 6 months. And that's unprecedented, particularly if you work in government, you understand what it means to hire 2,000 people in 6 months. We do intend, of course, then to continue with these capacities and to ensure that that resource is available. And so, yes, double-edged sword, a bit of strain, particularly when we had surges, but then also, I think we're leaving the health system in a better place now. When it comes to perhaps, and I've seen this question, I've often been asked, what was the spend for COVID-19? I think it would be interesting to hear, and particularly from yourselves who are academics, how do you delineate the spend for COVID-19 from beyond the health system itself to line sectors? For example, a lot of investments had to be put in place when it came to the water sector. Hand washing points, availability of water became absolutely crucial. And we all know those are social determinants of health. So it'd be interesting to see and read publications in terms of how they clearly delineate, and if there even is need to delineate, that resource in terms of how we're able to mount a response. When we get into vaccination right now, we've spread about 17.2 million doses have been issued in terms of jabs in people's hands, 17.2 million doses. In the beginning, and I do appreciate the COVAX facility, because much of the initial doses that we had did come through the COVAX facility. And then later on, of course, we had doses through different bilateral agreements and engagements with different countries across the world. And then, of course, eventually also Kenya was able to put aside close to 13 billion Kenya shillings for the procurement of vaccines, that being J&J vaccines. The story there is very interesting. I mean, we all, I think, remember hearing, very, very uncomfortable words such as vaccine apathy, vaccine iniquity across the world. And as a country, I think more so Kenya, there was a time where we did, like I said, have resources on the table, money available to procure whatever needed vaccines, whatever vaccines were available and that were approved by WHO. But it was almost nearly impossible. There were a lot of geopolitics at play. There was a lot of haggling. I can tell you, having been in the inside circle of this response, there are times where we actually had to look at freight and trying to track your own plane to ensure somebody doesn't get away with your batch of vaccines or consumables. I think for me, the beauty of that is it should be a resounding lesson for African countries, for all countries really, that there are certain elements of the health sector that touch on the security of the country beyond just the simple well-being of people. And I use simple here casually. We need to definitely have those tough conversations on what self-reliance looks like. I think countries across Africa do need to put their foot in the game, and Kenya has been able to do this. As it stands right now, I do agree with Pollard, supplies are not an issue right now. We actually have in stock close to 10 million doses. So these are unused doses. They're in our cold rooms across the country. Are the doses being picked up as fast as we'd like? No. Are we seeing cases of vaccine apathy, fatigue? Yes, particularly now that we have fewer cases being reported each day, particularly now that communities are not as alert as they were before. In the peak of the pandemic, it was very easy to hear my auntie has COVID, my neighbor has COVID, someone else there has COVID. Right now, it's hard to sort of be around somebody who's tested positive for COVID. And so, of course, there's been, sort of lack of that, good uptake of vaccines. We are mounting a response. We're having campaigns now. We've seen suggestions such as what is done with GAVI and different ministries of health in terms of having a campaign day for vaccines. We're looking at, do we institutionalize a COVID-19 campaign day, much like the way you have a polio campaign day, and sort of do some mass vaccination for 2-3 days? Will that be a cost-effective mechanism? Is that something that we need to do right now, considering should I say, the levels of herd immunity that we have in our country? We have been able to do a lot of seroprevalence surveys. Those are available. We've published, and I'm glad I did engage in about 3 or 4 of those publications, where you could tell even early on in the pandemic, we were already at perhaps 40-50% in some of the high density areas in the country. And so right now, I'm sure it would be higher across the different parts of the country. So how do we mount a sustainable, cost-effective, evidence-guided campaign now that we do have 1, 10 million doses in store, and 2, that the jury is still out in terms of have we reached steady state? So these are considerations that we're looking at as government. We aim to continue vaccinating. We aim to continue putting in place advocacy measures to bring in more people. Now, as I conclude, perhaps, like I said, for us, the biggest lesson out of all this is that of self-reliance. It was very frustrating to be able to mobilize resources, but not to be able to use them because of constraints in accessing different goods and supplies. And so Kenya, as a country, has put in place what we're calling Kenya BioVax. It's going to be a vaccine plus other strategic commodities manufacturing company that has the involvement of government, but also partnerships with different pharmaceutical companies. And we've done this in record speed time. So in 3 months' time, we had resources from Exchequer, we have the land and the site, we have the master plan, we have a board, we have an establishment, a staff establishment, and we have different contracts that are already being signed right now, and that's sort of on its way. We hope that, of course, like many other countries, this being an area where we've not invested previously, it will be sort of a graduated type of investment. So starting with fill and finish, and then getting into other spaces. This will be expanded beyond vaccines to touch on other strategic commodities, such as insulin, such as antivenom. And so I think that's really, a good commitment from government. Of course, we're also partnering with Moderna. I think this was probably announced and it might have reached you. We will be part of the teams that are working with the hub in South Africa, Afrigen, and essentially we'll be able to put a Moderna plant here. They are going to share their technologies, which is important. And of course, then just another journey towards self-reliance for the country. So I think I'd like to end it here and perhaps just wait for plenary in case there are other questions that may come through. Thank you so much.
Well, thank you so much. David, what does it look like as seen from, from where you're sitting, part of the international donor community and coordinating agencies?
Thanks, Stefan, and Mercy and Andrew, thanks. That was a privilege to listen to both of you speak as well. And I think one of the things I'm struck by is how the situation in the pandemic keeps changing and shifting, right? I guess if we'd have had this conversation 3 months ago at the beginning of the Omicron wave, we would have had a very different conversation to the one that we're having now. And I guess we have to hope, and Andrew, you gave us some optimism there, that things are stabilizing and that we're moving towards the virus becoming endemic. But I guess one of the things that the virus has taught us so far is that that can change at any moment, and we still need to be vigilant. Stefan, on the sort of international response, what I thought I would do a little bit, just briefly, some of this has been covered by Andrew and Mercy, is just talk through a little bit kind of where we were with vaccinations and Vaccinating Africa last year with the international response, where we are now, and then some thoughts for the future. And I think there are a couple of lessons in the international response there. So I'll talk a little bit about sort of where we were in 2020 and 2021. And, you know, I think in 2020 when the pandemic hit, and you mentioned this a bit in your introduction, Stefan, there was hopes that the international community would get together and provide a truly kind of equitable response and look at procuring and distributing vaccines to all countries in the world in similar timeframes. And that was behind one of the aspirations of the COVAX initiative that Mercy mentioned, which is being co-authored by GAVI. And, you know, our original hope was that we would distribute 2 billion vaccines by the end of 2021, equaling 20% of each country's population. Again, pertaining, as Andrew said, to generally, on average, the elderly, the most vulnerable, the immunosuppressed, the healthcare workers where you have the biggest bang for the vaccine buck. Now, as we all kind of know, the situation didn't quite work out like that. And I think that there are a number of reasons why. And I think, and in Africa in particular, as a continent, struggled in comparison with others, despite the efforts of organizations like COVAX and others at the beginning. And why did that happen? I think there were a number of reasons. Firstly, Stefan, you mentioned it, it was the intense competition with high-income countries who had the funding, who were able to put orders down early, at risk losing money, in a market which actually, you know, we have to remember, prior to this pandemic, I think the global capacity for vaccine production was only about 4 to 5 billion doses. And over the course of one kind of phenomenal year last year, and thanks to the achievements of Andrew and others, there were 11 billion new COVID-19 vaccines, just those were put together. But at the beginning, competition was very intense. We also were hit by, throughout the course of the year, supply chain issues with manufacturers scaling up content, getting regulatory approvals, and then something which hit COVAX in particular. We had sourced a number of our early vaccine doses from India and from the Serum Institute of India, and you know, some of those arrived actually pretty early on in Africa, but with the sort of rise of the Delta wave in India, a lot of that supply chain came down. And so that did mean that there was a 6-month period probably after where supplies to higher income countries were moving forward fast, but the supplies that COVAX was able to provide for African countries weren't keeping pace with that. And I think, as Mercy said, it was quite difficult for individual countries on their own to do the sorts of deals with the manufacturers that got them earlier on in the queue. Now, look, when did that start to change? And I think there has been a real change in the vaccine market, probably over the course of the last 4 to 5 months. The last 3 months of 2021 suddenly started to see much more vaccine supplies being available. So COVAX did manage to distribute 900 million doses to 91 low and lower middle income countries under our portfolio by January this year, and 300 million of those went to Sub-Saharan Africa, including a number to Kenya, as Mercy mentioned. So we sort of got there, but what does that mean in terms of where we are now? And I think one of the really interesting things in vaccination now, and we've talked about this, in terms of the disease at the moment, we have cases that are tailing down towards kind of record lows that we haven't seen since the beginning of the pandemic, and deaths are also really quite low now. And I was struck by those numbers that Mercy mentioned in terms of the hospital numbers in Kenya as well. And so that is a challenge in trying to increase vaccination rates at the same time. So we're almost having the supplies becoming available at a time where it is harder to get them into arms, but there is still a really strong focus on this, and the picture is different across countries. So overall in Africa, I think we now have 20% of the African population has had 1 dose, and 15% of the population are fully vaccinated. There are really different numbers across the continent for different regions. Some really strong performers Rwanda has 60% of the population vaccinated. South Africa and Mozambique are around 40%. But we still have 14 Sub-Saharan African countries who vaccinated less than 10% of their populations. So kind of what are we trying to do from COVAX and with others to help? I think one of the positive things about the supply situation easing now is kind of for the first time, we're able to offer countries what we had hoped to do earlier, which is 6 months of supply security so that we can say to countries, what vaccines do you want? What types do you want? mRNA, viral vector, others. And when do you want them? And I think, you know, Mercy can perhaps speak a bit of this afterwards, but that certainty is needed when you want to plan vaccination campaigns. It's not easy to step those up immediately. So kind of having some of that security is really important. So that will help. And I would say in terms of kind of where are we now and where do we need to go in the future, certainly from the GAVI side, working with international partners, with UNICEF, with WHO, with the African Union task force, the focus has really pivoted to delivery and how we can support countries get more vaccines into arms. And you know, interesting. It was kind of interesting, Andrew, that you mentioned the Hong Kong data, because again, that was something which I've been looking at a little bit weak, and it's incredible actually that you know, partly due to the very low numbers of vaccinated people amongst their elderly population, it's almost the reverse of what's happened in other countries of the world. How the virus can still have a very, very strong impact, particularly in the most vulnerable. So I think the absolute focus has to be on raising vaccination levels amongst those cohorts, elderly, comorbidities, those who are immunosuppressed, to give them the biggest protection against the virus. And we're trying to do that working across international institutions, individually in countries that have challenges, low vaccination rates and low population vaccinated, to try and kind of basically the classic thing that sounds very good but it's very hard to do in practice, have a single team, support a single team in country with all agencies working together to look at what the individual bottlenecks are, because they will differ from country to country, population densities, cultural reasons, to sort of unblock. And there are 5 kind of core things that we're looking to try and do at the moment, 5 bottlenecks or 5 challenges that we're seeing. The first one is to make sure that we have, and Mercy, again, you talked a bit about this being a positive thing in Kenya, but high-level political engagement from kind of presidents and the heads of state downward to support vaccinations increasing, and then to back up the words with a specific plan that works, both at national level and really, really important in federal and regional levels, and the sort of levels that you need to make vaccination campaigns work. Secondly, recognizing the reality of the disease at the moment, and the fact that actually if you're able and you want to do this cost effectively and persuade people to take vaccines, it needs to be bundled in with existing health priorities and other routine vaccination campaigns, which is a better way of accessing and getting people who may be on the fence in terms of taking vaccines. You have to support that with addressing vaccine hesitancy. I was really interested to hear about that public-private part of things in Kenya, but how do you get risk communication, community engagement out there, counter perhaps some of the myths, and particularly very prevalent amongst young people that we're seeing through social media, the talk of some of the issues that are incorrect around the safety of vaccination. Fourthly, really focusing on what can we do to strengthen healthcare capacity, making sure that healthcare workers are properly remunerated, community healthcare workers, alongside some of the infrastructure that's been built up. And then perhaps also to help countries do that so that it works for COVID-19 vaccination, but also leaves a legacy to strengthen health systems, both in general for health priorities and also in the kind of to help prepare us either for what might come next with this virus, hopefully not, or for future pandemics in the future. And then fifthly, the challenge that there always is in this environment where you have a lot of international partners working together is how do you streamline the different funding chains and sources that are available and make the World Bank speak well to my organization and to UNICEF in such a way that helps the country do that and deliver that on the ground. And that's definitely been a big focus of work. But basically all in support of each country's national target. Now there are The WHO has set a global target for 70% of every country in the world to have their population vaccinated by July. That's going to be a real challenge. And indeed, some of the changes of the nature of the virus and others just speak to how difficult that will be. And so the focus that we are really pushing is working with each country in line with their own targets and plans to see how we can support and strengthen that with some of the focuses we've talked about. And then just let me end with just a couple of things on sort of what more can and should the international community do and help countries with. I mean, the first bit is what I've just talked about for the last few minutes, is really all international partners coming together, including with our bilateral donors and agencies, to make sure that we're speaking with one voice and we're really focusing on delivery and increasing vaccination, particularly amongst the most vulnerable. There are 34 countries that were highlighted at the beginning of this year that had vaccination levels at less than 10% at the time, where there's a real focus of attention, and that needs to remain. And that's for kind of this pandemic. I think the second thing which is challenging is we need to be ready to and equipped to be able to respond if the pandemic does take another turn. If we get a variant with another Greek letter variant of concern, they've happened on average every 4 to 5 months over the course of this pandemic. We need to be able to pivot and respond and try and make sure that we don't have a situation where lower income countries, lower middle income countries are left behind again. And I think some of the lessons we've learned will help with that, but we've also learned that funding is needed upfront very quickly to secure places in the queue. And that's something that my agency is working on along with others. And then I think finally, to speak to Mercy's point, I think that there is a real agenda to help global health security by further diversifying manufacturing capacity across the world, and in particular in Africa, which suffered so much. And there are a lot of initiatives underway. I know the one in Kenya is one of the biggest, but they're also in South Africa, in Senegal. And I think one of the roles that my agency and others can do, also as large purchasers of vaccines over the long term, is think how we can support some of those new initiatives so to help make them financially sustainable, so that they are able to have a market for their goods, both in peacetime and when pandemic hits. And that's a very complicated thing, but I think it's a really important long-term agenda to help Africa be a better place for the next pandemic as well. Thanks, Stefan.
Well, thank you, David. Well, one reflection I have on the contribution that all three of you make is that actually, look, we're reaching a point where all three of you can have a certain optimism around where we are now. And it's, I must say, we've been doing this conference now for a while on Zoom, and last year that was absolutely not the atmosphere. There is, of course, still lesson learning to be done, and I'm sure academics will do this for a very long time in terms of studying and so on. But I have just one comment, which you may want to comment further on, is that besides working at Oxford, I had other hats on last year, sitting in London in rooms where some of these decisions that sound nag and that you can't really call differently from vaccinationalism were taken. And I like very much David's point in saying one big lesson definitely from on the policy side, and that involves some of the economic thing and the way finance ministries and treasuries will operate. It's this very early ability to actually get strong commitments and contracted commitment, because once it goes out of hand, these contracts, these global commitments can't be made anymore. And in a sense, the period that we lost when even before Andrew could declare success were actually periods that in some sense we lost, because that was the moment with enough uncertainty, ambiguity to actually create commitments, and they were far too loose. So you could get actions as we had in so many capitals, whether it's on the producer side in India or in other parts, of course, in the Western capitals, on the financing at the right moments and the contracting. But anyway, that's the thing. Where I want to actually get a little bit is as well is that, one of the things we hear, and quite a lot of economists dabble into behavioral science and behavioral economics as well, is to actually the hesitancy question. How have we have we made a mess of that, and how did we do that? Or is it just something by their nature that it was almost unavoidable that this would come? I'm still a bit puzzled whether this, we can all say we should have worked better at it, but hasn't this must have been endogenous too, or part of what's happening? I don't know. I would just love to hear your own views in it, because it is clearly, as Andrew and Mercy, as you're saying, keep on vaccinating people now is important. And this is where probably one of the big hurdles is now, and it's still important. So I would just be very interesting to hear somehow your reflections on the hesitancy kind of issue. Thank you. Anyone who wants to go first?
Yeah,
yes,
I can kick off. But before I do, I just want to pick up on one interesting comment that David made, which is that we're not quite sure what the virus is going to throw at us next. I think actually we are pretty sure about what the virus is going to throw at us next. It's evolving to be able to remain fit, in other words, to transmit between humans. And in order to do that, it has to mutate, and those mutations will allow it both to be better at transmitting, which we're seeing that's to do with its binding to the surface of our cells. And the second component is to escape our immune responses. But that is to escape the immune responses in our nose and throat that allow infection. But it's not making mutations which escape the really important immunity that we have that prevents that really severe lung disease that people were suffering from before they were vaccinated. And so we are absolutely sure that the future is the virus will be with us, it'll transmit, and it'll cause infections. To get back to a reboot of the pandemic in a vaccinated or a previously infected population, you need a new virus where, for example, the whole of the spike protein that vaccines are made from is switched out. And just adding mutations doesn't do that. So I think we're pretty sure that the future is that the virus is with us. We're just not quite sure at what level it's still circulating at to cause mostly mild infections. And that a lot of what we're seeing as hospitalizations today are actually people who've got underlying health conditions who they get a relatively mild infection with COVID, but it tips them over the edge, just as flu does each year or other viruses. And it's a much bigger bar to prevent those mild infections than it is to prevent severe lung disease. So we do have a problem, which is a problem for health systems, but it's one that's a much smaller one than we faced beforehand. So I think it's just worth putting into context. We have a pretty good idea what is coming, and it's just going to be with us. To come to the hesitancy question, I think that there are great examples of how it's been managed well. And I think when you look at how joined up here in the UK, the government, the public health community, the scientists, and the media were in projecting messages which got very rapid uptake, I think very much helped by having a National Health Service which is pretty robust and allowed the rollout to happen. That I think is a great example of how things should be done. There may be some disadvantages in the way that the UK portrayed itself externally as in competition with other countries, being first and so on, which probably damaged relationships externally. But actually internally, that was very successful. If you look at the approach that some European countries took, which was much more discoordinated, partly as a result of their systems, but with undermining vaccines, with negative comments and amplifying safety messages, that probably led to a loss of confidence in some Western European countries. And I'm sad to say that some of that got very much amplified in Africa. Whereas in some of those European countries, things that some of the ground could be regained. There are parts of Africa where there was never the counter arguments put in place or the reassurance that could be done in some European countries. Also with that, one has to think about mandatory policies which were used in different forms across Europe, which are very interesting in that they, despite hesitancy, some of the mandatory policies actually did act as a nudge. So in France, the fact that you couldn't even have a cup of coffee outside in a cafe in Paris meant that vaccination rates went up by around about 10% at that time, when they had relatively lower rates in many other countries. So some mandatory policies can be useful as nudges to move people along. But then it's so complex. You look at some of the Eastern European countries, that's to do with the relationship between the population and the state. There are other countries where vaccines became political, with the party in power being in favor of them and trying to push them, the opposition seeing this as a political tool where vaccination could be undermined. And that was happening before the pandemic in some countries. So we've got this huge different reason for hesitancy depending on the different country that you're dealing with. But if you look at those unvaccinated people in most countries in the world, even today, it's much more about access and reassurance than it is about people who are anti-vaccine. And I think and I'm sure Mercy can give us some insight into this in Kenya, but if you look in many of the African countries with colleagues who I talk to, they still see the major problem is access. If you want a dose of vaccine, it's not there in your local football stadium or your pharmacy or the primary care physician in the village that you're in at that time. It's still an access problem that is a major component, and then also providing the necessary information.
Mercy, would you like to come in here? Yeah.
Yeah, sure. And perhaps Andrew's provided a good segue in terms of access. So for sure, access was a factor when it came to hesitancy. And for us, it's interesting, again, very complex. All the interventions that we put in place had a positive and negative effect in terms of hesitancy. In the beginning of the pandemic, we had a designated facility, for vaccination. So these were points that were identified as vaccination facilities. And there were only 3,000, and this is in a country that has about 11,000 health facilities. And so, of course, there are constraints. We had a lot of complaints from the public when it came to, yes, the vaccine is available and free, but it's 30 kilometers away from me, meaning I have to take a day off work, or I have to take a day off market and travel, who's going to take care of those costs? And that contributed to the uptake rates. And so what we did, is we sort of adopted one of the approaches that was utilized during the HIV pandemic years back, when we would have a distribution of condoms and moonlight clinics. I don't know if any of you practiced then or engaged then with HIV. And what you would do is you'd essentially identify densely populated areas then and go there to either distribute condoms or do HIV testing. So we use the same vehicle. We still have that vehicle available in the country. We still have programs, we call them the Moonlight programs. And interestingly, again, you'd sort of notice every time we did such a campaign, there'd be a high uptake in terms of uptake for vaccines. So we went to bus stations, we went to nightclubs, we went to markets where we knew we would get people. But then, of course, the challenge of sustaining that over a long period of time, it was difficult to be able to avail that service. Almost like on demand in high density areas. That was difficult. So what we're doing right now, at least in terms of access, is that we have both measures. We have teams that sort of identify a high demand area. We ended up partnering with churches. Sunday is a day where if you're a politician in my country, then you need to be in a church service because everyone congregates into a church. And so we use the church and we put vaccination points in churches. And that helped, in terms of trying to have easier access to, and of course, then uptake of the vaccine. In terms of, the hesitancy issue and nudging people, it's very interesting. There are times when we introduced vaccine mandates, green cards for you to be able to access meetings, for you to be able to access some restaurants. And in the beginning, perhaps a week, 2 weeks, 3 weeks post the announcement of that mandate, yes, many people would come in and get vaccinated. But then, of course, there was the issue of enforcement, having the resources to be able to have those public health officers and the police. And yes, I do know there are issues of human rights when it came to, the pandemic response. It was difficult for you to be able to actually continuously check that if you're coming into a restaurant, that you're vaccinated. And then, of course, these were times where we'd had a lot of economic disruption. It's difficult for you to turn away a customer to your small restaurant when you're still trying to eke a living. And then of course still practice, government directives on presentation of vaccine certificates. So it was a bit, mixed picture. Again, it's interesting. And I think at the time, you know, the NHS, I mean, we envied you because there was sort of a command and control center. You sort of are able to centralize your response. Kenya is very different. We have 47 autonomous governments who run health. So you're talking about 47 governors who you have to convince that this is an important intervention. And beyond even convincing them, you have to almost expect that they will implement what you guide as policy from national government. And so again, their disparities were seen. We had governors who really took it upon themselves. You know, they were there front and center with the media, getting vaccinated, getting their families vaccinated. And in those communities, in those counties, yes, you saw rates come up. Everyone was lining up. If my governor is doing it, I will do it. Of course, then we have areas where the political commitment may not have been that strong, particularly, you know, in some counties. And in those counties, you saw, you know, slower rates. We had incidences where, you know, we had a lot of disinformation, misinformation. Again, you'd see different patterns in those counties. It's interesting, we should talk about the vulnerable. We have counties in Kenya that are sort of the ones that carry the biggest burden of cardiovascular diseases, non-communicable diseases, particularly because of their geography and other factors that we still don't know. In those communities, till today, they have the highest vaccination rate, 70%, you know, 65% compared even to the national average of 26%. And so it's interesting to note that in those communities where you had the elderly and those who mostly suffer from diabetes and they're very obese, and it's an interesting picture in our country in terms of our demographic, they got vaccinated. They were afraid. They had the message, and fear then served as an incentive, as a nudge to go in and get vaccinated. Of course, in counties where we have migrant communities, and we have about 11 counties where the communities are pastoralists and they keep moving from one end to another, it was very difficult to be able to maintain that uptick in those regions. We considered, you know, paying people to get vaccinated, and we sort of went through all the elements of different kinds of nudges that you can avail to the population. And I think for us, the biggest lesson was for the next pandemic, it is clear there's going to be need to have those medical anthropologists, behavioral economists on the table, working with us, policymakers, working with us, public health practitioners and epidemiologists in the design of some of these interventions. As we speak today, we recently you know, declared masking voluntary. I think that was probably a week ago. And believe it or not, doing almost 100,000 doses a day of vaccines, we're now at 20,000 in a span of a week. So we lost a continuous 80,000 people that we were sort of vaccinating. And so it's interesting when it comes to this policy space in terms of what interventions we put in place and what nudges that, you know, you can put in place. But for Kenya, it's absolutely clear. It is a heterogeneous country, 47 governments. And so the different nudges should be adaptable to the different counties. And it's a different ballgame than the NHS. I wish I was managing this when I was in the NHS. It would have been much easier for me, I can tell you that.
I just to add one comment. I'm not a big fan of mandation personally. And I think it's easiest to do in a setting where you've got very high uptake of a public health policy. So here in the UK, mandatory use of vaccines would have a majority in support of it, because most people have been vaccinated and they can't understand why other people, the small proportion who haven't been vaccinated. But you have a very small impact by mandating in that setting, where mandatory policies are most useful is where you've got very low uptake and you really want to protect the population. And of course, in that setting, the majority of the population are against vaccination, and it's very difficult politically to introduce mandation in that setting. And if you look at other major public health interventions like seatbelt laws in cars, smoking cessation in public places, all of those happen at a point when the vast majority of the public had already reached a point where they think it's a good idea, and it's a small minority of voters who are not interested.
And Stefan, if I could just come in, I noted that Abidemi had a question in the chat, which is a really good one. Can we say that COVID-19 vaccine hesitancy when the vaccines haven't reached those who are interested in taking them? And Mercy will have some views on that, but I wanted to come in because this is something that we've been looking at in the context of studies, and there's quite a lot of pulse studies across Africa showing strong support for people who would take vaccines if they are available in the 50, 60, 70% range. So I think, you know, whilst there is definitely vaccine hesitancy in Africa like there is everywhere else, I think that the challenge of of access, now that the supply situation is easing and getting vaccines to more points so more people can take them is still a real priority. And you know, I think there's a lot of unmet demand in an economic sense still there. I mean, unfortunately, some of and Stefan, the final thing, the question you raised about could we have done things differently? And I guess one thing that we did see is even in times where there was the supply constraint last year, some of the different regulatory decisions, I won't name vaccines here, but that were taken by European agencies and different things, which made sense in a context of their own individual mandate and maybe even the own individual vaccines they were looking at, but did cause broader global disruption and trust. And there were vaccines that we had in the COVAX portfolio, which countries didn't want to take, even in the height of the pandemic in there. So I think that's interesting. And I think, you know, one of the things I was really interested that Mercy talked about is, you know, developing a Kenya CDC, developing strong national and regional institutions that can be trusted, so that you know, helps engender greater trust and confidence. Thanks.
That's great, and if I may add, and show disagreement if you don't agree to these things, but one of the things that also was happening, of course, senior policymakers in each countries thought they were just communicating to their own country and to their own political economy, and actually they were communicating to the world. And I think there's something there that there was a real underestimation of how it was amplified, how it was passed on across the world, and because a lot of the communication made sense locally. And yes, it's a good point, and I take Abidemi, if you don't quite agree enough, please come further and comment further on it, and I'll definitely put it to the panel. But it is maybe it allows me to actually move to an additional question around the hesitancy, is that, you know, and maybe there was actually, David, I wanted to ask you as well, and others I'm sure will have a view, is that was there something very exceptional about the nature of hesitancy in this case relative to hesitancy you may have with other vaccination campaigns? Is it all because it's new? Is it all kind of thing? Do we think this is actually just a matter of time? Are there precedents of slow uptakes or issues to do with that? And I would just, I wonder whether it can be put into the context of vaccine hesitancy in other contexts, maybe.
That's a good question. Let me just give a few top line responses to that. So there's definitely something that is specific about the nature of COVID and the fact that I think, you know, the vaccines, whilst declared and we've seen are safe by regulatory agencies across the world in the WHO, there is something about it being new, which I think is different, especially if you look at how long it takes to plan a routine vaccination campaign and introduce new vaccine campaigns that we do as part of our kind of routine business. They're years in the planning, and the campaigns around them are carefully calibrated, and a lot of the technologies around routine immunization have been around for so many years that people are used to it. You have evidence in communities of where that's been helpful and effective, and it's something that people have done for generations. So there is a definite difference in terms of managing that here, and I think that there are different, and we're trying to think through those lessons now. And Mercy, you talked a little bit about this when we're trying to also bundle COVID-19 alongside other services, so it becomes part of something that is more kind of tried and tested and trusted in the community, I would say. Thanks.
So allow me to have a Mercy.
Yes, Stefan, could I just make a quick comment? And just because also I do have to run, we're having some people living with disability event starting in about 15 to 20 minutes. So I do have to jump off. Yes, I mean, very, very good question. We did notice that in Kenya, particularly, we've done very well with our childhood immunization program, and it's targeted to, you know, those under 5s all the way to from birth. And because people and mothers have ordinarily done this and have been sort of accustomed to doing this, it was easy for certain factions of the population to accept going in for the COVID-19 vaccine. Now, the COVID-19 vaccine is the first adult, you know, population vaccine, and adults sort of, you know, it was different for our country. We struggled in terms of trying to mount a vaccination program for adults as compared to, you know, a very robust infrastructure for children. So that was a factor in it. I think also, interestingly, the church in Kenya, the church is a key partner. If you look at issues of family planning, I'm sure you're aware of the role and the influence that the church carries. And in the beginning, interestingly, we had very good support from the church, but that turned at a point. We actually had statements come out from different religious organizations who are sort of disputing the value of the vaccine. And we saw rates go down in terms of vaccination. But here's the interesting thing, and sad as well, the leader of that church actually passed on from COVID-19, the person who signed off that statement. And the next week, again, we saw an upsurge of COVID vaccine uptake. And so this is a very complex issue, and it's sad that that would lead to that he'd have to sort of, you know, lose his life for people to be able to do that round turn. But I think the role of disinformation will be very important in future pandemics. We have to find a way of how we manage that. We have to find a way of how we allow for, you know, rights in terms of use of different technologies, but also govern the use of that. And we don't have an answer. I do, you know, I'm not a believer of sort of strangulating people in terms of access to information, but there's going to be need to look at that, because future pandemics and disinformation will definitely need to be governed. So that's all I have for now.
Yeah, Mercy, can I just ask a very small additional thing quickly? You made this really good point on the self-reliance. You also said somehow, you know, there's possibly some positive benefits on the health systems that we get, and you said actually people should research it, and I'm really with you there in terms of, you know, there is maybe even some excess spending that is happening on all kinds of things we wouldn't have done, and strengthening of systems and so on. That's a research thing. The one question I would want to have to you, and then please then go if you need to, but then the others maybe can answer as well. Do we risk, by now getting ourselves really better prepared for the next pandemic, that we skew health structures and expenditures in often the way we prepare ourselves for the last crisis, and we don't do it for the next kind of health challenges? Do you see a risk in your department, political pressure, that you're going to be having to skew everything towards this kind of issue, maybe at the cost of other things, and how are you thinking about this?
Yes, for sure. You know, as with anything else in the world, there's an opportunity cost. We did invest heavily in COVID, and much to the detriment of other disease groups. I do remember early on in the pandemic, decisions were being made between availing DT4G, that's a pediatric prescription for HIV, which we had in stock, and we were sort of saying, okay, this could last us for a year, so then let's, you know, sort of focus on the sort of cannulas and, you know, all the things that we needed for COVID-19. And yes, so I think wholesomely, yes, there is definitely more resources in the health sector. Within the health sector, and this is part of what Kenya is doing right now, we are looking at our investment plan, our strategic plan, and sort of trying to then balance things out. You know, so here is where we are with COVID. Yes, we've learned these lessons. Yes, we're putting together Kenya CDC. Yes, it will have this support coming in. But then what are those, you know, essential services that we forgot about? And how do we then plow back to them? How do we push more investments in that space? How does the whole health sector sort of get back to that steady state in terms of investments? And you know, interestingly, in terms of financing, and again, very controversial within the country, but we are looking at other instruments, earmarking certain taxes for health sector. We're looking at other, should I say, innovative mechanisms of funding health, social impact bonds. There's all these discussions happening in terms of how do we really sustain the health system and ensure that there's more resource and money available for it. Will it be sustainable going forward? I think it's going to be interesting. And it's almost as if, I mean, and I like what Andrew said, you know, we know what's going on with COVID. So it's going to be interesting to see how treasuries react with what's going on with COVID. You know, how do we translate this from us, the public health practitioners, into then the money people? And how will that look like? That would be interesting to see. I don't have an answer for it right now. Right now, yes, we have the resources, but it's going to be interesting that we need to put some nudges for the treasury people to have learned what we learned as well. But sorry, guys, I do have to run. Yeah.
Thank you for that last comment. And maybe, well, thank you, Mercy. And if you have to go, please log off. And if I could ask for the two others, you know, what would be the wrong lessons from the pandemic?
Well, I thought that the answer that Mercy gave was just perfect, actually, because the key lesson is around health system strengthening, which is something GAVI is involved in. It's something critical for those countries. I'm sort of speaking out of turn as a non-economist, but my understanding is that the impact of the pandemic in the first 2 years was around $30 trillion. I'm picking that out of my memory. If you think about that unimaginable figure, the investments that are needed to strengthen health systems are nowhere near that order to get them to a point where they could be better able to cope with just the day-to-day disease we deal with. If you have finance ministries focusing, for example, on building the health systems just to be better able to cope with COVID as it is today, which is becoming a disease which is not overwhelming, but is still there in the background. That strengthening that's required doesn't cost $30 trillion, but it does mean that you're much better prepared for next time. So I think a lot of what finance ministries needs to do is to do what they were doing previously, which was trying to think about how to strengthen health systems, but to do it much more urgently. Because the problem was that we needed to have been where we're aiming to be in 2050. We should have been there last year, and we haven't gone there. So as far as diverting other resources, we need to have better surveillance. We don't have that for viruses generally, but that's a small cost in this big pot that we're talking about. And we need R&D, but again, that's a small cost. A lot of that needs thought, and I know GAVI is working very hard on this about how do you provide the pull-through so that when academics like me make a vaccine, that industry is prepared to then be involved in that process, even though there's no commercial benefit that's obvious at the moment. But these are all tiny costs in comparison with $30 trillion. If you want to invest in pandemics, $30 trillion would get you a long way.
Yes, excellent. David, maybe you're the last word now.
Just very good. I think, so Stefan, it's such a big and an interesting question, right? And in some ways, it's sort of, you would think, given the overall global health and then subsidiary economic, and then, you know, Andrew said at the beginning, even some of the social and political costs of this pandemic, you could think, well, you couldn't possibly spend enough money relative to other things to prevent this happening again. But at the same time, I think there is a risk. I'm involved actually in a G20 task force as a GAVI representative that's looking on pandemic preparedness and response and what do we do more. And I think always funding flows, international domestic funding flows, do follow the last thing that's happened. And I know, Stefan, you've done a lot of work on crises, right? Whatever we do know is that the next crisis won't be like the last one. So I think as we're thinking about this, I mean, there are a couple of things. One is to what extent can we focus on things that have like dual use investments, right? That both strengthen foundational aspects of health systems at the same time as building up future resilience. And, you know, Andrew mentioned surveillance, and there are other things that are benefits both nationally to a country and then kind of regionally and globally as well. And I mean, and so I think that's a really important focus of any debate that we have on pandemic preparedness. But then I think I'd probably go a bit further, which is even outside of that, you know, we know prior to COVID, health systems were chronically underfunded in many countries in the world, and we are going to be running into, you know, we have rising debts as the result of this pandemic. We have other things which is urgent to spend money on in the recovery, and I am worried globally maybe not in the next few months, because the focus is still on the pandemic to a certain extent, although waning a little bit because of what we've talked about, is will we get a legacy out there? And the legacy needs to be just as much building sustainable health systems, you know, as well as it is on thinking about the next pandemic. The two will work hand in hand.
Excellent. Thank you. I think we should close it now on this note, but can I just say it was an absolute privilege to have you debating these issues. And on behalf of the whole CSE community, thank you so much for your participation here. Thank you.
Thanks for having us.